Let's talk today about ovarian reserve and AMH and unpack how the ovaries age under the combined influence of biology and fertility treatments. Most clinicians are familiar with the anti-Mullerian hormone or AMH, which is a marker of ovarian reserve. And that's something which you need to think about if you've not done it. It behaves like a fuel gauge for the remaining pool of eggs. What is the new study from Shandong, published in Reproductive Medicine Online, asks which factors actually change how fast the AMH drops over time in infertile women. The team looked at 4,245 infertile women who had at least two AMH measurements between 2012 and 2021. They calculated each woman's annual AMH decline and grouped them into slow, medium, and fast decline. Then they used multivariable models to see which clinical factors are independently associated with a steeper or fatter slope. These accelerators of AMH decline stood out. First, more than 3 ovarian stimulation cycles for ART. Women who had more than 3 cycles showed significantly faster annual AMH losses than those who had fewer cycles. Secondly, tubal adhesions. Think of blocked tubes or damaged fallopian tubes were also linked to a steeper decline. Third, advanced age, which aligns with what we already know, ovarian aging, but here it is quantified in the context of infertility care. On the other side of the spectrum was polycystic ovarian syndrome. Women who had a slower decline in AMH, so their hormone levels remains elevated for longer. That fits the biology of PCOS with its large cohort of small follicles. But it raises a counseling challenge. High, slowly falling AMH in PCOS doesn't automatically mean preserved fertility or egg quality. Interestingly, factors may suspect, such as ovulation induction alone, previous ovarian or tubal surgery, BMI, or baseline AMH, were not significantly associated with rate of decline in this cohort. So a signal seems to be strongest for treatment intensity, tubal pathology, and age. What does it mean? First, that AMH should be viewed dynamically. Trends over time, especially for severe stimulation cycles, which may be more important than a single value. Second, clinicians who want to pause and reevaluate strategy after 3 stimulation, particularly in older tubal factors patients, that's something to think about. It reinforces the need with PCOS to interpret AMH in context and not just focus on quantity, but also quality. What are the challenges of this study? It's a retrospective and regional and not the final word. It pushes the field into thinking about ovarian reserve not only as a birth assigned trait, but a trajectory that shapes diagnosis and how to use ART.